ठीक है, मेरे ख्याल अभी हम एडमिट करते हैं.
Assalamu alaikum everyone, a very warm welcome to this session. We are going to kick off the session in the next couple of minutes. We're just waiting for a couple of more participants to join in. So bear with us for a couple of minutes, please. Thank you. Assalamu alaikum to all the participants and welcome to this 11th session of the Impact. I'm just going to check sound. So can everybody hear me who is unmuted? Can you please confirm that the sound is okay?
Yes.
Yes.
Okay. So this session is entitled the implications of COVID-19 on surgical disciplines, and the remit of this session really is to get an insight as to how COVID has affected the practice of predominantly surgery and allied specialties, and how people have coped with this. We are very fortunate to have two excellent speakers from both sides of the Atlantic, and we are hoping that their experience and their their thoughts are going to benefit everybody who is attending the session. So I'm just going to very briefly outline how this session will run. But before that, I must give thanks and acknowledge the various people who have made this session possible, which includes the Government of Sindh and the Department of Health in Sindh, who have organized and coordinated the participation of multiple institutes. The Yarane Watan program run by the Government of Pakistan, and King Edward Medical University for coordination in Punjab province. And we've got participation from all four, or in fact, in addition, Azad Kashmir as well. So thank you very much for all the participating institution and their vice chancellors and people who have coordinated it. The session will be as follows. There will be two presentations. The participants, in order to make sure the decorum is maintained, the participant will be muted for the first part of the session when the speakers are presenting. I would request that during these presentations, if you have got any questions, kindly put it into the comment box. The moderators will be looking at the comment boxes and will pick up these questions and address them immediately after the presentations. After we address some of the written questions, we will then unmute the participants and we will open the floor for questions directly to the speakers. When that happens, I will be grateful if you can keep the questions or comments brief, because obviously we are constrained by time and we would like to wrap it up before the stipulated 2 hours. So I'm going to first invite Dr. Syed Ghazanfar Hussain. He is an associate professor of surgery and a program director for colon and rectal surgery fellowship, and he practices at the Ohio State University Medical Center in Ohio. He's got a fair bit of academic commitments, and he's well versed into talking about I think Ohio was affected reasonably severely from COVID, and I think people have learned quite a lot of lessons. So, Dr. Ghazanfar Hussain, you've got the floor. Thank you.
Can you see my screen okay?
Yes.
Okay. Well, thank you for inviting me to speak in this forum. Thanks to the Impact organizers, and especially Dr. Najib Ahmed for the invitation. It's truly an honor to speak in this forum. I'm Ghazan Hussain, and I'm a Dow graduate from 1997. After that, I did a surgery residency at Harlem Hospital in New York. This was followed by a laparoscopic surgery fellowship in the University of Rochester, and then a colon and rectal surgery fellowship at Brown University in Rhode Island. Finally, I was accepted in a faculty position at Ohio State University Medical Center, and that's where I practice now. So my first disclaimer is that I'm not a coronavirus expert. I'm just a practicing surgeon. I do not know a whole lot about the virus itself. Probably you guys know a lot more than me. Today's talk, I'm gonna just talk about my personal experiences and a few things that we saw at our institution. As I mentioned, I'm a practicing surgeon. I do both major and minor surgical operations on a regular basis. I employ both laparoscopic surgery as well as robotic surgery in my practice, and I do a fair bit of endoscopy as well. And this is where most of my talk will rotate around today. Now, the first case of coronavirus was diagnosed in Wuhan on 31st of December. And within a month, the first case was reported here in the United States in the state of Washington. About 2 months down the road, we had enough cases that the governor of Ohio, the state that I practice in, passed a moratorium on non-urgent / elective procedures. So by the order of the governor, all hospitals in the state of Ohio were prevented from doing non-emergent surgeries. And we'll go into that detail as well. As we passed through the COVID crisis, the things started getting a little bit better. And on 22nd of June, the moratorium was lifted. We were allowed to do elective operations again. At present, there are more than 4 million cases in the United States, and we have experienced almost 150,000 deaths. So what I will hope is that the area that I'm going to concentrate on is between the time the moratorium was placed and the time that moratorium was lifted, the so-called kind of return to normal. So I'll start with my personal perspective about this whole COVID crisis. So the first thing that affected me, and I think it affected pretty much everybody who was directly or indirectly involved in taking care of COVID, was the amount of anxiety and stress that came with it. When you see people and healthcare workers around you, people you know, getting sick on a daily basis, you start thinking that, I'm doing this, I am supposed to report to the hospital every day, but I can also get sick. And not only I worried about myself, what bothered me even more was the concerns about my family. Pretty much every day when I returned from work, especially days after operating on a patient, on a COVID positive patient, that was the biggest thing at the back of my mind. Many of my friends, many of our colleagues who either had elderly parents at home or had somebody who was immunocompromised, they chose not to go home. I know of at least a few doctors who got a room in a motel and just stayed there for the entire time that they were on call. The other thing that added to the stress was the PPE shortage. So I was, of course, in constant communication with my friends in Pakistan. And just like in Pakistan, we were facing the same problem here. As soon as the crisis hit, the supply chain was completely disrupted. And we had problems with PPE. We did not have enough masks or gowns in the hospital, so they started rationing it. I mean, that's something that I've never seen before. Also, what we did was to reuse the masks, which again is something that was inconceivable just a few days ago. So that not having access to PPE, of course, added to that stress. As an institution, we decided that our trainees will not be taking care of COVID patients. And that was done with good intention. We did not want to expose our trainees. So what that meant is for every COVID patient that was on our service or every COVID surgery that we did, the attending surgeons, the supervising physicians had to do it themselves without any help. So of course that became even more stressful. Not only that you're operating on a patient who has COVID, but now you're operating by yourself without any help. So all of these things, and then constantly changing guidelines. These added to the stress. So the stress was the first thing that I think of when I think about COVID at a personal level. There were, of course, some professional issues as well. The hospital had a policy of not allowing patient families during the crisis. So we had to communicate. I made sure that I communicate with my patient's family. So that's, of course, an additional charge on you. That's something that you have to do in addition to your daily work. So I would sit down at the end of the day and then spend even more time just to call each one of my patient's families to let them know. It was rough on our patients too. Many of our patients who underwent major, big cancer operations, and they were there by themselves. They recovered by themselves. They stayed in the hospital sometimes up to a week, 10 days by themselves without having to even had a single opportunity to see any family member. So I cannot imagine what they went through. Our institution had placed limitations on how many patients can be seen in the clinic at the one time. They did not want too many patients waiting in the waiting area. So they cut down the number of patients we could see in the clinic. To compensate for that, we were asked to do telemedicine visits. So these are the remote visits, which I know in Pakistan too, there are several NGOs as well as the governmental organizations that are doing these telemedicine visits now. So that was something very new to me. Our primary care docs, our primary care colleagues were doing it for a very long time, so they were very well versed with that. But for surgeons, this was something new, so we had to learn it really on the run. We had to learn it very quickly. And now almost half of our visits at any given day are telemedicine visits. Then the next question was, there was a lot of debate within the surgical community if we should do laparoscopy or not. There is this concern about, and we'll discuss that a little bit in detail in the next few slides. There's a concern about laparoscopy creating aerosol, and then because of that, there was a concern that I would expose myself or my team to COVID if we did these operations laparoscopically or robotically. So you're caught between trying to protect yourself and your team and doing the best for your patient. In the end, most of us continue to do MIS. We'll discuss the literature. There's really not a whole lot of support not to do laparoscopy. So we did not really change our practice in that sense. Other concern was, of course, our case volumes just plummeted because we were not doing any non-essential cases. So if you see here, this is my productivity. The line across the red line, the vertical red line marks COVID. And you can see before COVID and after COVID productivity, there's a sudden drop. So that was another area of concern that, our productivity has really gone down because of the crisis. Now, at a personal level, one thing that I did, and I'm sure all of you do as well, are the cleaning rituals. Now, I'm not a germaphobe. I'm not the kind of guy who carries hand sanitizer in their pocket. I've never done that in my life. But once we started seeing COVID patients, it just changed the way I look at hand sanitizer, and they've changed the way I approach these cleaning rituals. So I would go to work, immediately change my clothes, my shoes, work the whole day, and then change again. On most days, I would shower before coming home. Of course, the days that we operated on COVID positive patient, I would shower. Sometimes I would even hesitate to come back home. I left hand sanitizer in the car. I would sanitize my cell phone before entering the house, which again, all of these things which we took for granted changed within a matter of weeks. Now that was how it kind of affected me. I mean, there's so many other things that we can talk about, but I can't go into that detail. The next thing I'm going to talk to you about is how my institution dealt with all of these crises. The first thing they did was to build the capacity. So they knew that they will receive a lot of patients, so they wanted to open up beds. So of course, the first thing to do was to cancel all the elective operations. The hospital usually runs at about, somewhere between 95 to 97% capacity. So the hospital's pretty much full in any given day. But because of cutting down all of these elective operations and non-urgent visits, our capacity came down to, our occupancy rates were like 30 to 40%. So we were ready even before COVID hit Ohio. In addition, like many other places in Pakistan, we had a little tent set up outside of the hospital in case if we had an overflow. Hospital made fantastic contingency plans, which were tiered contingency plans that if, we have 100 patients, we'll do this. If it's 200 patients, we'll do this. And if it's more than that, we'll move on to the plan. There were color-coded plans, and I'd be more than happy to share it with anybody who would want details of that. For surgical staff, we were all made to go through ventilator training. In US, surgical training involves critical care training. So most of us spend about 6 months in doing critical care training. So that was a good refresher for all of us. And also we did multiple online courses for ICU pharmacology to kind of come back up to date with the current medications. The hospital asked for volunteers. The acute care surgery and the trauma surgery group also does surgical critical care in our hospital. So the hospital was worried that once the COVID surge occurs, all of these acute care surgeons will be pulled out to do ICU care, and there will be nobody left to do trauma surgery and acute care surgery. So they asked folks like me whose practice does not necessarily involve trauma care, but they asked us if we wanted to volunteer. And that was a good plan because then they had a huge list of names to call upon if they needed us. Thankfully, we never got to the point where acute care surgery was completely overwhelmed. And I'm thankful that I was never called to do trauma call because it's been a very long time since I've last taken care of a trauma patient. In terms of surgical flow plan, as you can see, our hospital had a very simple plan. It's anything but simple, really. There are multiple layers. It took us a while to actually know the protocol of what to do when a COVID positive patient needs an operation. This is very, very small, and my intention was just to put it up there, not for you to read it, but to know how complex that plan was. This is a simplified slide of the same plan. The way we approached a COVID positive patient who needed an operation was that we would do surgery only if it was absolutely necessary. So that's number one. Only essential personnel were involved. So the medical students were, of course, sent home. The trainees were sent home. All the helpers in the room were sent home. It was just the surgeon, the nurse, the scrub tech, and the anesthesiologist, and that's it. So we kind of cut down to bare essentials and to minimize exposure, of course. We had designated ORs where we did COVID cases. The patient would come in, they would get intubated in one room where only the anesthesiologist would be with the patient to minimize exposure, of course, to the rest of the team. As we all know, intubation creates a lot of aerosol. So we didn't want the whole team to be in that room. And now, since there is aerosol in that room, rather than the team going into that room after intubation, we move the patient out to another room, a fresh room, once the patient is already intubated, where the surgical team would be waiting for the patient to arrive. And then we'll do our surgery Once the surgery was complete, the team would leave. We would walk outside of the room, and the anesthesiologist alone would extubate that patient, because extubation, again, is an aerosol generating procedure. And once that is done, again, the patient would be moved to the first room where they were intubated in and recovered there. So we completely eliminated recovery room to minimize exposure. Once the patient was awake enough to go to their room, they would just go to the floor from there. We would wait, our institutional policy was to wait 28 minutes between the cases, and that's the time that it takes in our hospital system for the air to circulate through the operating room. And then after that, the room would undergo terminal cleaning. They would wipe down everything, and then you treat it with ultraviolet lights. So that was our protocol for the patients who required COVID surgery. Now, in terms of what procedures were considered essential and which were not, now this is the entire Department of Surgery came up with a list of their procedures. Again, I'm not going to go into the details of any of these procedures. What I'll tell you that these were really just the essential procedures that really needed to be done. Everything else was just taken off the schedule. Now, in terms of aerosol generating procedures, I know we talk about that a whole lot in surgery. In terms of from a general surgical point of view, the important ones are, of course, the intubation, when the patient is getting intubated before surgery. If you have to do a tracheostomy on a patient, that's a very high-risk procedure, or somebody who requires an endoscopic exam. Fortunately, most of the abdominal procedures themselves are not considered aerosol generating procedures, so that kind of minimizes the risk that we face as general surgeons. So as we discussed, on March 18th, there was a moratorium that was placed on surgery, and only patients who were whose life depended on that operation underwent surgeries, or patients whose disease condition would be considerably worsened if they did not receive an operation. That moratorium was lifted on May 1st, and initially we only started doing ambulatory procedures. We did not want to do any procedure that would require a patient to stay in the hospital and occupy a hospital bed. We continued to do that till June 22nd, when the moratorium was completely lifted, and now we are doing all the elective operations like we did before. The difference, though, is that all of our patients now, whoever comes in, regardless if they come in for surgery or for an endoscopic procedure, or even for a test like a CT scan, they need to get COVID testing first and have a negative test before they can enter the hospital. So that's just, towards the end of my talk, I'll just talk about a few miscellaneous issues. I hope I'm not over my time here. So a couple of things that affects us as surgeons. The first thing that a lot of times that confuse me at least is what kind of PPEs should I be wearing when I'm dealing with COVID patients. So American College of Surgeons came out with these guidelines. These are University of Kansas guidelines which were adapted by American College of Surgeons. So for low-risk patients, they said the American College of Surgeons recommends that it's just surgical mask is sufficient. I'll tell you that in our institutions, that's not what we do. In our institution, if you're seeing any patient, low risk or no matter how low risk they are, you still have to have some sort of eye protection. Either you have to wear goggles in addition to surgical mask, or you have to wear the mask with a shield. Now for patients who are suspected kind of intermediate risk patients, American College of Surgeons recommends that you wear eye protection with face shield, use a surgical mask, use gowns and gloves. And patients who are COVID positive, we have to wear, the college recommends that we wear either a PAPR or an N95 respiratory mask, of course with eye protection, gown and gloves. Now, as we discussed before, the role of MIS and robotics have been questioned in the time of COVID. A lot of people think that pressurizing, creating pneumoperitoneum under pressure generates mist, which contains virus, and it can can be transmitted to the surgical team. There is no clear evidence of that. Actually, nobody has done a head-to-head comparison between laparoscopy and open surgery. Well, what we have done at our institution is that we avoid evacuating pneumoperitoneum to atmosphere. So we just don't open the ports after doing, say, any type of cholecystectomy or hernia repair. We use some sort of a smoke evacuating system. So the smoke goes through the evacuator, which has filters in it, rather than just letting it out in the atmosphere. Similarly, we are not using valveless trocars anymore. The valveless trocars, the one that's most popular is the air seal type. We don't use them anymore because they leak. And then the ultrasonic dissectors, because they produce a ton of vapor, we don't recommend using that for during COVID crisis. A couple of papers. This is, again, these are the papers. That's the reason why a lot of people start worrying about the role of laparoscopy. These authors in 2014 looked at laparoscopy, and they found that there were some carcinogenic elements in the laparoscopy smoke. Similarly, another group, I believe from Korea, looked at 11 laparoscopic procedures, and they found hepatitis B virus in the laparoscopy smoke. So this is why some surgeons believe that laparoscopy should not be done in COVID positive patients. However, there's really I personally do that. All of my partners do it. There's no direct evidence comparing it to open operation. I would leave it up to you guys to decide for your own self. In endoscopy, again, upper endoscopy is considered a high-risk procedure, a high-risk aerosol generating procedure. Colonoscopy is not. For upper endoscopy, I would suggest that you do make sure that you wear N95, especially for patients who are COVID suspect. Their viruses it has been isolated in saliva and mucus and feces. Of course, all of these secretions you're exposed to when you do endoscopic exams. And advanced procedures, endoscopic procedures that require long, prolonged insufflation should be avoided. Now, this is just a quick guideline about what type of PPE to wear when you're doing endoscopy. So for low-risk patient, you should have a cap, goggles, surgical mask, and gown and gloves. For intermediate risk, if you're doing an upper endoscopy. So now intermediate risk are patients who have some symptoms, but they are kind of, they're still COVID negative, but clinically there's some concern that they may be COVID positive. Lower endoscopy is same as low risk. For high-risk patients are the ones that have very obvious symptoms or have a COVID positive result. You have to wear, in addition to the hairnet, you have to wear goggles or some sort of a face mask and an N95 mask. And then you, of course, have to wear a gown and gloves. So what's in the future? What's on our horizon? We should all try to get used to the new normal. It looks like that it's going to last for a little bit. It's going to stay with us. It's not gone yet. At least in the United States, it's not. The telemedicine is going to continue to play an important role for outpatient visits. I think it's going to continue to have an increasing role in our practices. And then I think we're going to continue to test for COVID for all patients coming into the hospital. I think many hospitals have already started testing physicians. I think that's also going to become a standard in the near future, where hospitals would periodically be testing their physicians to make sure, to ensure there is no transmission from physician to patient. Now the concern really for us, at least in the United States, is the second peak. We are experiencing a really robust, a real second peak. So we don't know if we're going to go into the shutdown again. As I mentioned, we just reopened elective operations. We are all concerned that if we're going to make full circle and we're going to be back to the time where we were only doing essential operations. So that's, the COVID is here to stay, at least in the foreseeable future. I don't think we're going to get rid of it for another maybe 6 to 12 months at minimum, and we are preparing that way, from a surgical point of view. So I'll end here. I thank you all for listening. I hope this was somewhat helpful to the audience, and I'll be happy to take questions.
Thank you very much, Dr. Zamfar Hussain. So at the moment, as I've initially said, so the benefit of people who have joined after the introductory talk. So I'm the moderator. My name is Dr. Najib Ahmed, and the session will run with the participant currently muted. But if you've got questions, you're very welcome to type it into the chat box, and the moderators will pick it up, and we will address them towards the end of both presentations, after which we are going to open the session for direct questioning and interaction. So thank you very much for a very, an insightful talk. I'm going to invite my second speaker, Mr. Asad Qayyum. He is a consultant ENT surgeon, and he is also, he practices in Peterborough City Hospital and Hinchingbrooke Hospital. He is a clinical director for the ENT surgery program in the Northwest Anglia Foundation Trust, and overall East of England. And he has got substantial experience in ENT surgery. And of course, there are various surgical disciplines, but disciplines which are particularly interacting with the upper aerodigestive tract are disciplines where, COVID has had significant implications. So I would request Dr. Asad Qayyum to please share the experiences and, of course, what you have learned. So your floor. Thank you.
Thank you very much, Zanfar. I will just start by sharing my screen. If you just give me a minute, please. Right. Can everyone see? Najib, can you see me? Is it all right?
Yes, everything is fine here.
Great. Assalamu alaikum to all the guests in United States, UK, and in Pakistan. My name is Asad Qayyum, and as Dr. Najib has mentioned, I am based in a place called Peterborough, which is in England, which is a very small country compared to the United States. We're about 70 miles north of London, and our city is famous for the old cathedral, which is present where some of the couple of famous queens are buried. And this is the hospital where I work, which is called the Peterborough City Hospital. I originate from Pakistan, and I graduated from Dow Medical College in 1996. Finished my basic surgical training at the Civil Hospital Karachi, and the first milestone in my life was St. Mary's Hospital in Paddington, where I spent the first 3-4 years of my life in the United Kingdom. The subsequent milestones in my life have been, I trained in the east of England in ear, nose, and throat surgery. And during that time, I was placed at the Sanger Genome Institute, where I did my initial research and master's from the University of Cambridge. I then went, after completing 6 years of my training in ENT, subsequently went across to Australia and Darwin, where I did a fellowship in otology, and then came back and spent the last year of my second fellowship at Addenbrooke's Hospital in Cambridge, completing a fellowship in implant surgery and then the second one in rhinology. As you all know, that COVID has had huge amount of implications on majority of these specialties in medicine, and including particularly in ENT. And in the United Kingdom, we have lost a few ENT surgeons to COVID. So our specialty has been hit very hard. Also the fact that just simply by nature of the work that we do, we are exposed to aerosols within the outpatients environment, as well as in the theater. So essentially, we are always at the forefront of being exposed to the COVID-related risk. The problem that we all face is that, like yourself, like the US, like anywhere else in the world, nobody knows about COVID. We are all in it for the very first time, like you all are. And information on COVID is evolving, and the virus keeps on changing. We do not know whether the virus is going to provide herd immunity or the immunity. The most recent report that came from, in fact, China only last week said that the immunity lasts only 3 months if you get it, and then you're exposed to the risk of virus again. So the bottom line is that this is an evolving situation, and we have to learn to organize ourselves and live with the virus. And we have to learn to constantly improve on our own selves from each other's experience, how we can perform better, perform safely, not only for ourselves, but also for our family, as well as for our colleagues, etc., around the world. The thing that we have to understand from the COVID's perspective is that in the last 6 months, the practice in medicine has changed. We were told when we were learning surgery that you will learn surgery at the arm of your mentor. So you have to work hands-on, very, very close to your trainer in order to learn surgical skills, be it outpatient consultation, be it surgery, be it anything else. However, it is very difficult to train and teach and learn and treat patients in the current environment where the practice in medicine has changed so quickly. What was unthinkable last year is now considered to be the new norm. And the challenges that we have to overcome are huge. As I said earlier, we have to ensure that we are safe, our trainees are safe, and our staff is safe. The resources that we have are finite. Every institute, big or small, has finite resources. If you are looking at the statistics of big institute and you're sitting in a small institute, you think that the resources are huge, but those resources are finite to the size of that institute, so they are not infinite. It all depends where you're looking at it from. So the important thing is how to best utilize those resources, work within the realms of the limitations of the institute that you have, and at the same time ensure that the rest of the population who will continue to have the regular health-related problems are not neglected in the process of providing adequate safety and treatment to the COVID-related patients. It's a very difficult juggle. And in our hospital, when COVID started, and just very much like Azanfar mentioned in Ohio, all elective work had stopped, and we only concentrated on doing the cancer-related work and providing tracheostomy cover. The other thing we had was, because we were the only specialty who had the skill of performing tracheostomy to unload the ITU, we were not redeployed. So we kept on doing what we did best, and that was ENT surgery and helping the ITU reduce their burden. What I'm going to talk about during my talk in the next few slides is that how ENT surgery has evolved, how ENT outlook has evolved, and how we have started to see our patients in the current life to provide protection to ourselves as well as to our patient. We have gone down the route of telemedicine as in the US. We have also gone down the route of remote consultation, and electronic communication has now started to play a huge role in our daily lives, something which was very unthinkable even 6 months ago. But you just have to do it because that is what is best for yourself and for your patients. Telemedicine historically was always practiced in some specialties in the field of medicine, but it never really took off. But if you notice now, in the last 6 months, the technology for telemedicine has evolved. In fact, the platform that we are using right now, Zoom, was pretty much unheard of 12 months ago. And now almost everyone has got Zoom and Microsoft Teams and Cisco platforms on their telephone, because those are the modalities we are using to communicate, reducing our footprint in the hospital to save ourselves, save our colleagues, and protect the patients. There are still ongoing concerns about telemedicine, which is the safety on the internet, the digital security to ensure that the data breach doesn't take place, and lastly, to ensure that we adhere to the norms of regulations around consultations performed from this new platform. So what is my current practice or current practice in ENT at the moment? As you all are well aware that we have, in the world of ear, nose, and throat surgery, we are always exposed to, we work in very close proximity to the patients as much as the ophthalmologists do, the dentists do, and the oral and maxillofacial surgeons do. And essentially we cannot complete our examination and formative plan of diagnosis and management unless and until we've had a peek within the areas primarily responsible for harboring COVID or generating the aerosol. So what we have started to do is our outpatient area is divided now into the
I think we have got some communication issues. If you can just bear with me for 1 minute, I will try to ensure that this is being addressed. Just bear with me for a minute.
Can you hear me now? Can you hear me now, Najib?
Yes.
Yes, we can hear you. Yeah. If you can restart your screen share, and I will let you know where we lost you.
Right. Okay. Are we good there?
Yes. So I think we lost audio around the time when you were discussing initial telephone consultation prior to seeing patients face to face.
Fine. So we start with a telephone consultation. After in the telephone consultation, we take a detailed history. And the entire history taking process is done on the telephone. After the telephone consultation, if we have to do any investigations for these patients, such as a hearing test, an audiogram, an MRI scan, or a CT, we refer the patients for those investigations. And then we review the patients and bring them into the clinic. In the telephone consultation, we are able to decipher whether these patients will require a nasoendoscopy or will they not require a nasoendoscopy. So if they require a nasoendoscopy, or if we understand that they've got a discharging ear with a perforation, they go into a room, separate room, where the air exchange mechanism is live. If not, then we see them in a normal consultation room, because the amount of aerosols that are produced while normal speaking would usually disappear within a few seconds. And also with the mask in place, they are very much restained to behind the mask. And then once the initial consultation has taken place, a management plan is organized. We then follow these patients up with the investigation results or follow-up appointments over telephone to ensure how the treatment plan is going ahead. if they require surgery, they're directly then added onto the waiting list for the operation. So this has essentially reduced 3 outpatient visits to essentially 1 outpatient visit. But this has changed how we practice. So our clinic template has now got where we used to have face-to-face slots. We now have a telephone slot followed by a face-to-face slot, followed by a telephone slot, followed by a face-to-face slot. So it's a new norm, and we're learning to work in this new normal. Now, whenever any patient travels to the hospital entrance, there is a questionnaire they have to fill to ensure that they haven't traveled from any country where COVID is present. They have to declare that they haven't been in contact with anybody who has got COVID. There is an infrared temperature check. In the UK, for the last 1 month, face masks have been mandatory for all patients in the hospital and for the staff. However, from yesterday, face masks in the UK have been made mandatory for all public places and public transport. And there's a £100 fine if you're caught not wearing an appropriate mask. When we, like in the US, when we come into the outpatients, we have to change our clothes, wear the scrubs, which are worn during the consultations. We all have to wear, essentially because we are in ENT, we have to wear a full PPE, particularly during consultation ideally, but definitely for all airway generating procedures. Our consultation rooms have been changed, so the surfaces are now clear and clean. For chlorine-based cleaning solution to be used for wiping out all the surfaces, including the patient's chair, desks, everything, after every face-to-face appointment. So whilst we are carrying out a telephone consultation, the nurse comes in and cleans up all the surfaces to ensure that the environment where the next patient will be seen is pristine, clean, and safe. This was a little cartoon I picked up from the website yesterday, and it shows that generally, if you are in an area where a suspected COVID patient was seen, you just have to wear a fluid-resistant mask, proper gloves, and a disposable apron. Whilst on the contrary, if you are involved in looking after patients who are COVID positive or who are undergoing any aerosol generating procedure, you have to wear a full face shield so the eyes are protected, a FFP3 or an N95 face mask, surgical gloves, and a body cover which shields the bodily fluids and protect the surgeon or the medical staff or the doctor from being exposed to COVID. The limiting factor in our consultations is obviously we cannot perform any examinations without face-to-face contact. And that is one of the reasons why we are ensuring that the patients continue to be seen face-to-face. Very recently, last month, a very close colleague of mine from Birmingham, Chris Colson, devised literally, as I said to you in my earlier slides, we have to evolve with time and we have to rediscover and reinvent because this is the new way of working. And Chris came up with a very simple device of a normal face mask. He made a slit in it and put a few valves in it so that we could perform a nasal endoscopy with the face mask on. We actually moved on from this, and now in order to save money, what I now do is make a little slit in the face mask, put it on the patient's face, and put my telescope through it to perform the nasal endoscopy, preventing the patient from taking the face mask off. We have stopped using local anesthesia while we perform the nasal endoscopy. We just use cotton pledgets to localize and numb the nose. This prevents the patient from sneezing and reduces the dispersion of the aerosols. We have ensured that all our clinical areas are stocked with an AMI level 2 gown, which is essentially a barrier to fluid. As I said to you, the minimum requirement is to have 15 air exchanges per minute. But if you have 15 air exchanges in the room where the procedure is being performed, that means you can only do 4 procedures in an hour. The one that we are using is 40 air exchanges a minute, which means we just have to wait 5 minutes between the cases. So it doesn't really stop the flow of patients. We have to make sure that the visors, that the FFP3 or N95 mask is in place. And we have to make sure that we have an area where for doffing and donning. So a separate room where a PPE can be put on, and then a separate room so that the PPE can be removed and disposed of in safe disposal bins to make sure that nobody else is contaminated by that, and the aerosols generated whilst we are removing the PPE are contained within that room and that area. Not to forget, microsuctioning, a procedure that we perform to clean the ear canals, is if the eardrum is perforated, there is evidence in the literature that that can also be an aerosol generating procedure. However, the jury is out on this and the information on this is limited. But for the time being, we are practicing microsuctioning of the ears in the presence of a perforation only in a room which has got effective ventilation in place. And we do take all precautions and wear the full PPE. What is happening in the pediatric population in ENT? Well, we have stopped all elective pediatric work up and until June. Only emergency pediatric surgeries were being performed. Any pediatric surgery where we are working within the airway cavity, we had to take the full precautions of COVID, as Ghazanfar had mentioned, and anesthetic being done in a separate room, waiting about half an hour before the procedure is started, waiting half an hour after the procedure is completed, ensuring that during the intubation and extubation, only the anesthetist and the ODP is present in the theater and nobody else. I have now started performing my middle ear surgeries as of this month. So I've done 3 cases this month. Again, mastoid surgery is considered to be an aerosol generating procedure, and I'll show you we have taken precautions of how we work our way through it. So the high-speed otological drills that we use are essentially considered to be aerosol generating because the lining of the middle ear cleft and the mastoid has got respiratory mucosa, so it can harbor the virus. We have to wear the full PPE, we have to wear the face mask, we have to wear the eye protection, and we have to use some very fancy, complicated draping mechanisms, as you can see in this picture, where the surgeon is operating. The microscope is draped, but then there's an opaque canopy which is put over on top of the patient to make sure that the aerosols are retained within that canopy. And that makes surgery difficult because all instruments have to be passed from under the drape and you can't see them. And the surgeon and these nurse have to ensure that their hands remain within this drape throughout, which makes training very difficult because if I've got a trainee who comes in and I want to teach him or train him or take over from him when he's in difficult situation, it has to be done very meticulously to prevent spreading the aerosols within the theater. What is the future? The future is that the microscopes may be changed and we move on to doing majority of a surgery by using what's called a 3D exoscope, which is essentially like a microscope, but you don't look down the screen. You actually look at the monitor in front and you work through the monitor. And increased use of the endoscopic ear surgery, which I'm doing it, but it's a very limited number of surgeons. I think there are only about 8 or 10 surgeons in the UK who are doing endoscopic ear surgery. So yes, so that is probably going to be the new normal or the new area because we can remove a fair amount of disease without using high-speed drill. Dizziness and balance in the field of otology is one area where virtual clinics will have a huge role to play. We have actually started doing some virtual clinics and are still trialing it out, how we can do it. The way we have planned it is that before we see the patient for the consultation, we send out some questionnaires to them, which they have to fill out and email them back to us. During the consultation, in this case, we use video consultation, and patient is sent a detailed information leaflet of what we are expected to do of him, so that he has the camera in front of him, of his computer, of his mobile phone. And when we ask them to follow the instructions, they are able to follow them. The caveat to this is that majority of the patients who suffer from balance-related problems, unfortunately, are old and feeble, which means they are the ones who are most exposed to the risks of this virus. And if that is the case, then obviously we do not have an option but to bring them in, do one face-to-face diagnostic consultation, examination, investigations, and then everything else, including the vestibular physiotherapy, is carried on online using the digital media. The other issue is doing hearing tests on individuals who are hearing compromised. And there is a new device, which is, as I said, come on the market, where patients can have a hearing test without having physical contact with the otologist, and using this particular device to perform a hearing test. What is the future here? Well, there are commercially available endoscopes available on Amazon, which you can tell the patients to hold in the ear to show you a picture of what the ear looks like. They can send the video, photographs to you, and you can make a rough diagnosis. Smartphone apps to do hearing tests, and patients can send the hearing test to us. So all these things are on the horizon, and they have all taken over the internet, taken over the Amazon by a storm. And I've already started receiving, in my private practice, patients sending me photographs saying, this is what my ear looks like, what do you think, doc? In the field of rhinology, anosmia was recognized as is recognized as one of the symptoms of COVID-19. However, smell testing should not be used as a screening tool to diagnose COVID, and the limitation, and it is limited, limitation is present. The important thing in rhinology is, again, as I said earlier, in diagnosis, to limit the aerosol generation. And again, as you can see in this surgery, the surgeon has got his hands in a plastic gown or a plastic shield. This is a drape that we used to put on microscope, which the surgeon has put his arms through, and is performing his endoscopic nasal surgery through this gown, again, minimizing the generation of aerosols. Very difficult, because the nurse also has to make 2 holes in the gown and put her hands through the gown, and every instrument is passed through the gown. So there are difficulties in operating and in training. What is the future? Well, we have to probably go down the route of using more non-invasive approaches, a focused history. More CT scans might have to be done to diagnose, with reducing the face-to-face contact. We may have to have special suites to do nasal endoscopies, like the gastroenterologists do to do their endoscopies. And I think the future is in the direction of the immunological treatment of rhinological problems to reduce surgical interaction. And the implants and the dressings that we use in the nose should be focused more onto the biodegradable ones, to reduce pulling all of these things out in the clinic setting. In the head and neck cancer, the telephone triage service is being evaluated, particularly for the follow-up, the yearly follow-up for patients who've had cancer treatment for more than a year. We have generally the major head and neck surgeries do not produce any aerosols. However, where the airway oropharyngeal tract is penetrated, such as during laser surgeries or endonasal or endooral surgeries or robotic surgeries, where the airway, the oropharyngeal cavity is penetrated, we have to be fully prepared to ensure that we are protected against the generation of the aerosols. The future I think as far as the future of cancer is concerned, it is all out in the open in discussion. And the most important thing is to reduce the long-term follow-ups by doing it via the telephone triage mechanism. These are some of the useful links, and if you've got your phones on it, take some screenshots. They are ENT specific, and they will give some resources onto various organizations, including the American Academy, who are helping out and have provided various guidelines of how various ENT procedures can be performed by minimalizing the generation of aerosol, ensuring that the surgeons and patients are kept safe. Well, future, it's full of challenges. Challenges of training, challenges of teaching, challenges of operating, and challenges of ensuring that we and our families and our colleagues are safe. I'm 100% certain that there is going to be an explosion of technology in the next few years of how we intervene and interact with our patients and how we treat them. And I think the most important thing for all my colleagues, young and old, is to stand up to the challenge of the future, and we have to adapt change. If we do not evolve in time, we may not be able to make it. So we have to learn to change and adapt the challenge. Some references from where these extracts were used. And finally, this is my message to all of you. That will be the end of my presentation. Thank you very much.
Dr. Asad Kim, thank you very much for a very thought-provoking discussion around the practice of ENT surgery during these challenging times. We have got a few questions, so I think in the interest of time, we are going to open the session. I think it's more than an hour now, so it will automatically, the participants will be able to interact. I'm just going to check that this is possible. So yes, I think I would invite the VC of King Edward Medical University, Dr. Masood Gondal, please, to I think if you can reflect.
Thank you very much. I think आवाज आ रही होगी मेरी सईद साहब नजीब साहब
Janab.
I am very grateful to you. I think this was one of the most important webinar as we are going back to the normal, and the guideline about the elective surgery, they have been discussed by these two eminent speakers, and we have to adopt that change and accept the challenge. That was one of the important sentence which was among the, I think, the last word of the second speaker. As far as King Edward Medical University is concerned, I've already mentioned we have attached 7 hospitals, and during COVID, both the speaker mentioned about the telemedicine department as the outpatient department that was stopped. We had the tele-OPD, tele-secretary and tele-corona help desk 24/7. And that is still working, and that will be the permanent feature of King Edward Medical University. And during COVID, observing all the guideline and the provision of the PPE to all the workforce working in the surgical field, we continued with the emergency and the cancer surgery. But some of the elective
So I think we have got some connectivity issues from King Edward. We will go back to them once they are able to join again. I'm just going to pose a quick question.
And Najeeb Saab and Saeed Saab. One comment by our hospital, the director of surgical tower, Professor Ibrar Ashraf Ali, who is an eminent surgeon. He is there. He would
I think we will give a couple of minutes, or let's wait for a few seconds to see if the connection resumes. I think the connectivity seems to be patchy with the KE at the moment. A question which has come up, and I would invite both the speakers to reflect on it, is prior to surgery, are the patients being routinely tested for COVID, and how are respective institution managing the risks prior to surgery? Are you testing all of them? Are you asking them to isolate for a particular period of time? Are you doing CT or any other modality?
Yes, what is there is that all the patients, the first line, there is going to be a screening. The screening is being done by our residents. So once they are going to take the history examination, they are in full PPE. And once they to make a triage, then they call upon the pulmonology department, because it's an SOP which has been made by the hospital. In the wherever we are going to find the moderate risk or high risk that this patient can have COVID, we are going to ask them. The pulmonology department then look into the patient. We go for X-ray, and along with that, this patient is going to be deferred and going to be put in isolation, and the testing is being done. This is for the emergency cases, as Professor Khalid Masood Gondal has already told you, that we are doing the emergency cases and few of the elective cases of malignancy which are being done. And in the malignancy, wherever we think that there is any history or any contact or the protocol which is there to stratify these patients, that patient is being sent for the COVID test. And once the COVID is negative, then we are going to put that patient on the list. This is for the elective malignancy cases. And for the emergency cases, majority of the patient, for example, the trauma patient who is in dire emergency of going for an emergent procedure, you can't opt for it. But in those patients, what we are doing is that the team is going to have a full coverage of PPEs, and with food protocol, they are going to operate upon those patients. And Alhamdulillah, for the last 2 months, we haven't got, because in the initial phases, around 20 of my residents, they got the infection. And for the last 2 months, that has dropped down, and there is only one patient. And in him, when we went for the tracing of the contact, we find it out that he had a contact with one of his host lite who was looking after the patients in the COVID patients in the medical department. And that is the possible contact through which he gathered the infection. So this is my observation. But my question is that we have started with the HVAC. We are regularly changing the HEPA filters. But one thing is important is that that is going to put constraint on the financial constraint onto the administration. And I don't know how long they are going to cope with that. And that is going to be one area where our apprehension is that there is higher chances that we can have a surge in the reinfection of healthcare professionals. So my question over here is that the centers where who are using the HVAC system or the central air conditioning system, any precautions which have been taken over there which is helping them out, or what are the, because we have gone through various protocols, the various guidelines. These guidelines varies from one institute, one organization to other organization, and that those put different questions in the mind, or conflicting concepts in the mind of the administration. How to settle those?
Sure, thank you very much. I think I'm just going to ask both the speakers if they have actually had similar issues within their own institutions. I suspect that these are more administrative issues. But I will invite both the speakers to Dr. Zamfar Hussain. Have you had any similar issues around HEPA filters and the overall way to manage the air quality in your theaters and the wards?
No, I think one of the benefit is the fact that the clinical engineering maintains all of that. There are, I know that there are certain environmental standards that need to be maintained for the hospitals, and there are even more strict criteria for the operating room, which are in place. I'm not aware of any changes to those standards. The standards that were in place prior to COVID, we are continuing that. I know there's some talk about negative pressure rooms for COVID positive patients. We do not have negative pressure rooms in our ORs. Most of our ORs are positive pressure ORs. And outside of some of the, some bronchoscopy suites or some of the thoracic ORs which have negative pressure. So I'm not sure if I'm answering the question that was asked, but as far as the HVAC is concerned, we have not run into any issues. And we've not made any major changes to that either.
Okay, thank you very much. Dr. Asad Qayyum, have you encountered any logistical issues around air quality maintenance in the environment?
So I can relate to the colleague from King Edward very, very closely, because being an ENT, we are closely monitoring all of this. So I personally have been involved in, and there is a huge amount of conflict on this. The more data you see, the more confusion you're going to get. So with respect to the outpatient area, we've never had any form of active ventilation system installed, just normal windows, fans, air conditioning, heating, the lot. In outpatient areas, there are two methods that can be employed. So you can have an active extraction system installed in the outpatient areas where airway generating procedures, aerosol generating procedures are going to be performed. Those extraction units should already have a UV. What there is, they draw the air in from one channel and the air is blown out through the other channel. And within it, there is a UV light and there is a HEPA filter. The average time of the HEPA filter in the unit is about 5,000 hours. And once the 5,000 hours, this is the average machine that we have. And the cost for that is about somewhere around 4,000 to 5,000 pounds. The benefit is it covers a room which is about an average consultation room. And you can have windows open, you can have air conditioning running, and there's not a problem at all. On the contrary, when you talk about so that's one thing, which is an air purifying mechanism which can be installed in the clinic. The second thing is having an air extractor unit installed in the clinic, which in the outpatients, which is basically extracts the air, blows it out of the outpatient area into the open environment, and circulates fresh air back into the consultation room. The important thing on that one is that a HEPA filter has to be in place. You need two HEPA filters, one where the input of the air is, one where the output of the air is, because you do not want to be blowing out virus out into the environment either. So that is the thing that has to be considered. For theaters, we already have got all those filtration mechanisms in place. Nothing major change, no major change has to be done, because the ventilation system, which is temperature, humidity control, already has got the HEPA filters, the UV filters, and the extraction mechanisms in place. The only problem is that those extraction mechanisms, the air change is about 15 air changes an hour, and that is the minimum that you need, and which means that when you intubate and extubate, you have to give half an hour between patients before you can bring a new patient into the consultation room. So those are the limiting factors. How the most important thing is to avoid a COVID positive patient coming into your surgical area. And the Department of Health UK guidelines are that any patient who comes in for surgery has to be him or her and their family have to be isolated for 2 weeks before operation. 48 to 72 hours before surgery, they have 2 COVID tests, which should be negative. If the test is positive, we don't operate. And the third thing the Department of Health has said, that we still have to consent the patient for COVID-related risks of complications, which is an ITU admission and intubation, and death. And the reasons why they're important is because the specificity and sensitivity of these tests are not 100%, number one. And number two, patient can still contract the COVID virus in the 48 hours before their surgery. And in that case, the numbers that come from China tell us that the risk of mortality is 21%, almost 1 in 4, if you operate on a patient who is COVID positive. The problem is not with the surgery. The problem is that these COVID patients, if they're symptom-free and they're intubated, they initiate a response which can then push them in the direction of ITU and prevent extubation. I hope I've answered the question.
Thank you very much. I think, yes, these are difficult decisions. I suspect that in a resource-constrained environment, the various departments have to discuss and identify the areas where the resources should be best deployed. And I think Dr. Asad Qayyum has identified very nicely the areas where, currently in the UK, the air environment is strictly maintained. And I think that hopefully that will answer some of the the questions arising around that aspect. I will just put one question to Dr. Ghaffar Hussain, which has come through, which is, any specific surgical complications or patient presenting predominantly with surgical complaints with COVID-19. Have you encountered any, or have you come across, in your professional discussions with colleagues, which you would like to share?
So what we saw initially was before we were really accustomed to COVID, the first few things we saw were vascular patients who were coming in with blood clots. And at that time, we really did not know that COVID also causes, thrombosis. So that was very, now in retrospect, we know that that's what was happening. Those patients had some underlying vascular pathology to begin with, but then they came in with acute thromboses. And few of our initial colleagues that got exposed to COVID was that way. Those patients came in, and as Asad just mentioned, they came in and they went through an operation. We never even suspected that this is COVID. And then in their recovery period, they developed this fulminant pulmonary, SIRS syndrome. And most of them ended up in the ICU. Few of them even expired. So that was one of the things that we saw in terms of unusual kind of complication of COVID presenting as a surgical issue. We've had a lot of patients, especially in the line that I work in, colon and rectal surgery, we had a lot of patients coming in with bowel issues as well. I don't know it's tough to say if their bowel issues were caused by COVID. All of those patients had underlying medical conditions to begin with. But the vascular compromise, the vascular thrombosis is that was very obvious to us that it was COVID related once we learned about that in retrospect.
Okay. Thank you very much. I think Asad has really nicely identified how the risk is managed prior to surgery in in the UK/NHS environment. In your institution, Ghaffar, is it of a similar way how you're managing patients? Are you testing them? Are you isolating them and the family? Just briefly reflect on.
So that's exactly, it's very, very similar to what Asad described. So everybody that steps into the hospital is screened, employees as well as patients. So they're screened with a quick questionnaire, which talks about fever, symptoms, and whether or not they've had any contact. and then they get their temperature taken. So that's for just anybody who's coming in. Now, in addition, if somebody's coming in for surgery, they get a PCR 100% of the times. Now, for emergency operations, of course, it's not possible. So for traumas, we assume that they have COVID. So we do full precautions with N95 respiratory masks and shields, goggles, and of course the gowns and gloves when operating on trauma patients. For emergency operations, where we have about an hour or so, we do rapid test, which is available within an hour, and then send out the PCR at the same time. So if the rapid test is negative, we go ahead and take them to the OR. And we've not had a whole lot of issues where the rapid test was negative and then we later learned that their PCR came back positive. So that's only for emergency cases, somebody with bowel perforation, somebody with high-grade bowel obstruction, or somebody who has a limb-compromising thrombosis. That's the only time we're using rapid test. Now, for patients who are coming in routinely, we do PCR for them as outpatient, and we ask them to self-quarantine themselves for 2 days prior to the surgery. Of course, it's not a foolproof method. There's no way for us to ensure that their patients are truly following the quarantine directions that they're given to them. But that's a protocol that we're following, that they get PCR. If the PCR is 2 days prior to their scheduled operation, PCR is positive, then of course we cancel the surgery. PCR is negative, we go ahead and do the operation.
Okay, thank you very much. I'm just going to ask the audience if there is any questions. Can you please unmute yourself, introduce yourself very briefly, and pose the question. I have got a couple of questions on the written format. But if there is a question from the audience or a brief comment about what we have discussed, I will invite whoever wants to ask to please unmute themselves, introduce themselves.
For me, Najib, from Dr. Najma Khoso. What about the prophylactic prescribing of anticoagulants if we are operating patients in emergency or for elective surgery? No, we do not prescribe prophylactic anticoagulants because none of our surgeries last that long that we have to do any prophylactic prescribing. Secondly, in the region of ear, nose, and throat surgery, these are quite vascular areas, and usually we are operating within close confines. So we electively avoid any form of anticoagulations in these patients.
Thank you.
So I'll add on to that. From a general surgical point of view, we use prophylaxis routinely for all of our operations, excepting for trauma patients or where we are worried about patients who are very high risk for bleeding. COVID or not COVID, all of the surgical patients get a prophylactic dose at the time of surgery.
Okay. Thank you. Just a very quick question. Has any institution from the participating speakers using CT as a guiding tool for risk stratification?
Not that I know of at our end, Najib.
We are not. No, we are not. But it's interesting you bring this up. The first patient that I ever operated on with COVID was diagnosed based on a CT scan. So the radiologist called it. So the patient had bowel perforation. We were not even thinking that the patient has COVID. He was very sick. They were in extremis to begin with. So we attributed everything of their, their clinical demise because of all of that to bowel perforation. And then as I'm reading through the report, the radiologist said that, it looks like that they have these lung infiltrates, which are highly suggestive of COVID. So then we applied the brakes before taking them to the OR, did a rapid COVID test, and they were positive. So that being said, we are not routinely employing CT scans to screen patients.
I think the question is probably raised in the context more of the general surgical patient, where most of the patients prior to surgery, very exceptional circumstances when they don't have an abdominal CT, and whether, including the thorax at the same time is something which, should be considered. So I think there is a mixed understanding. I don't think that from the radiologist perspective, that CT can provide the information in a way which is called robust in every patient, and therefore, it has been suggested it should not be used as a modality to risk stratify patients. But if there is a patient who is going through a scanner, it's always beneficial to at least image them up to the hilar, because most of the time the COVID related findings are basal, and if those are picked up, then perhaps that they can be appropriately used, particularly in the care of the emergent surgical patient. So I think that should sort that issue out. Again, if there are any questions from the audience, we are quite happy to take it. You will probably have to unmute yourself and ask the question. There are a couple.
Earlier, I think somebody, I believe, asked a question about surgical complications, general surgical complications. So I forgot to mention at that time what we have witnessed, and now there's a lot of papers coming out on that as well, is later presentations for almost all surgical emergencies. Even trauma patients, so somebody fell at home and injured themselves pretty bad, but just because of the fear of coming to the hospital, because they're worried that they're going to get exposed when they come to the hospital with COVID, patients just don't want to come. And it's perhaps the right thing to do, but unfortunately, many of the patients who actually need surgical care, many of them are presenting late. So we're seeing a lot of patients coming in who otherwise would have presented much, much earlier, but just because of the fear of COVID, are now coming in at a much later stage of their disease compared to what we are accustomed to seeing.
Sure. I think there were a couple of questions which were not related to surgical specialty. So a couple of them was about testing, which obviously I don't think we have got the expertise at the moment to address them. I would ask, however, about the rapid testing, Dr. Ghazampur Hussain, about, this is something which is used more across the Atlantic. Mm-hmm. We haven't actually, I don't know, Dr. Sadkayyum, if you have come across this rapid testing scenario, but this is not what, has been prevalent in the UK. So is that, are you satisfied with the sensitivity and specificity of these kits, or are there any question marks around them?
So there's certainly question marks around that. There's, I think the reported sensitivity and specificity is much lower than the PCR test. But given the circumstances, we don't use it routinely. As I said, the only time we use it is somebody who requires an emergent operation, and we have about an hour or so where we can wait before taking them to the OR. I am not aware of anybody in our practice any patient in our practice who, as I said before, who had an initial negative to a rapid test and then became positive with PCR. So we've been using that. I've personally used it for several patients, and each time the test is negative, those patients did end up being negative. So I think the short answer to your question is that yes, there's been a lot of question about sensitivity and specificity. The ones that were reported initially, we now know were perhaps not very accurate. I don't know the exact numbers, but I know it's fairly, it's not even comparable to the PCR numbers in terms of those attributes.
Sure, sure. So we are just going to give a couple of minutes to see if there are any questions. I am just going to display the email address for people to get in touch with if there is a need. This is the email address for the impact. If there are any questions or points you would like to raise or get in touch with us, this is the email address to use. We are going to send some feedback form, and we will be very grateful if you can kindly reflect and provide us feedback. I think the feedback is particularly important because it provides a way to improve these sessions. And until we get people to reflect and provide us with this, it's not possible to improve and change as per the requirements. So I think that we have covered most of the things which have been put to us. I would like to thank both the speakers on behalf of all the participants. I'm sure that your presentations and your reflections on various topics have really benefited all the participants. Particularly Dr. Ghaffar Hussain, who is quite late in Ohio. So thank you very much for joining at such a late hour, and we are thankful for your participation. And thank you all of the people who have joined us on Zoom and on Facebook. Inshallah, we will organize the next session, and we look forward to welcoming you all. So look after yourself, stay safe, and thank you. If there's any questions, kindly email and please provide feedback. Thank you very much. Take care. Allah Hafiz. Assalamu alaikum.
Thank you. Assalamu alaikum.